Hello, and welcome to Dead Air Live. Thank you for joining us. Tonight's topic is understanding mood and anxiety disorders. My name is Zohar, and I will be your host. Tonight, we're very pleased to have a special guest in the studio with us, Marianne McDonnell. Marianne is the co-founder and chief executive officer of Step Up for Kids, a nonprofit organization for supporting children with bipolar disorder. She also has written several publications, scientific publications, and has a book coming out next year with Random House. She's also the owner of the South Shore Psychiatric Services with offices in Cambridge and Marshfield. Welcome.
Thank you.
The show is about mood and anxiety disorders. Let's first talk about defining mood and anxiety disorders.
Okay. Well, general overview of mood and anxiety disorders, just to differentiate a little bit. Mood disorders include dysthymia, which is sort of a mild version of depression, major depressive disorder, bipolar disorder, or cyclothymia, which is a milder version of bipolar disorder. And they all have, we can talk a little bit more in depth about the actual symptoms. Anxiety disorders are things like generalized anxiety disorder, panic attacks, so panic disorder, obsessive compulsive disorder, social phobia. There are specific phobias, post-traumatic stress disorder. So there's a number of anxiety disorders, and they present very differently because most of the avoidance or impairment in their life is related to fear of either specific or generalized situations.
Okay.
So one is related to mood and the way a person feels and their motivational level and how functional they are, and the other is mostly related to fear and anticipation, worrying.
Okay, good. Let's start first with depression. Depression is one of the most commonly diagnosed disorders. How do you know if somebody's depressed?
Depression is one of the most commonly diagnosed, and it is actually the leading cause of disability in the United States. It is a disorder that can cause a significant impairment. People with depression usually have a loss of motivation. They can have changes in their appetite or sleep patterns. Things that they used to enjoy, activities or socializing, they lose interest in. So you'll see a person start to withdraw a little bit. Maybe they just don't have the energy that they used to have. They're not as productive at work. And there's different levels. So somebody may just not be themselves and be a little sad or tearful or down, all the way to a severe impairment where they can't function and they're disabled. And there are just different situations that cause depression in people's lives, and most everyone will have situations that cause them to be really sad. But there are some people who can't sort of snap out of that, and some of it is a biological underpinning. It's familial. It is a hereditary thing, so you'll see more in families. And in the severe cases, it really can lead to a person being significantly impaired.
Okay. You talked a little bit about situational depression versus maybe something that's biological. Most of us have felt depressed or feel depressed every now and again. How do we know what's a normal depression and what is more serious?
Okay. A lot of the situational depressions come from experiencing financial difficulty, a loss of a job, a divorce or a breakup of a relationship, a death, or just other significant stresses, changes in jobs and moving, relocation. And some people can really adjust to those stresses. Of course, if you lose a loved one, or your marriage breaks up, or you go through some sort of financial stress, then it's going to impact your life. You're not going to feel as happy. And some people may, sleep a little more or not be as hungry or overeat to sort of soothe themselves during those times, but still be able to get to work. They may be tearful, kind of bummed out, down, but they're able to function. And it will pass with time. And other people really get knocked down from those kind of situations where the depression really kind of takes over their life. They're significantly impaired. They're crying a lot. They really are down. They're not motivated to do the things that they usually like to do. They withdraw. Some people get very irritable and crabby. And some just sleep excessively. Others can't sleep. The sleep can go either way. They can either just want to sleep all the time and stay in bed to sort of, just sleep their life away so they don't have to feel. And others can't sleep because they feel so bad and they can't stop thinking about things. And the same is with appetite. Some people will lose a lot of weight. Others will gain a lot of weight. So it really speaks to a level of sadness, hopelessness that really interferes with their functioning and their ability to lead a normal life for a significant amount of time.
Okay. So let's talk about treatment then. Treatment both for the person that maybe is situationally depressed, or treatment for someone who's more seriously and or biologically, clinically depressed.
Right. Well, depression responds to therapy really well, and there's a lot of research to support that. So you always would start with some therapy, and therapy can be really helpful for a person who's gone through some sort of stressor, to sort of have somebody to talk to and to be able to figure out, how do I work my way out of this? But when a depression really is knocking a person down and they can't even begin to work through things in therapy, maybe they can't even get to therapy because they're so depressed, they can't even get out of bed, they certainly, medication may be indicated in that kind of a situation, because they won't be able to work through the issues in therapy without taking the medication, which will lift them enough so that they can do the things they need to do to feel better. And medication in a situational depression is sometimes a temporary situation, and they may not need to stay on that medication for a long time. They may participate in therapy and use the medication for a certain period of time and then stop it, and they may not have future depressions. People that have a familial depression or sort of a biological underpinning for depression, or that they're chronically depressed, they've had bouts of depression their whole life, it may warrant that they stay on medication for a longer period of time, or they may find that when they try to come off of it, that the depression returns even though everything's good in their life. So it's really, you evaluate each individual and decide what's best for them. But therapy's always indicated as well, in addition to medication, if that's needed.
It's important to get therapy as well.
Absolutely.
When I've had this discussion with friends or family, people always talk about the fact that we're so over-medicated. And especially with depression, it just seems like there are lots of antidepressants out there. A lot of people are on antidepressants. I just want to underscore the point that both therapy and medication work very well hand in hand. One way that we've talked about using medication is when you have a headache, you can take an aspirin and it helps you get the job done, whatever it is that you're doing. And so would you use that as a similar kind of analogy with medication?
Absolutely.
For this
I think that, if you look at the fact that 9.6% of the population in the United States will experience a mood disorder at one point or another, not all of them are going to be severely affected, but at some level they will be. If I was to tell you that that same percentage of people had diabetes or hypertension, you wouldn't hesitate to think that they should be treated with medication for that. You would never expect somebody to that they should be able to control their symptoms or be able to prevent their blood sugar from going up or their blood pressure from rising. You would understand there's a biological reason for this, and we know there's biological reasons for depression, that the neurotransmitters are either not functioning well or effectively, or that there's not enough of a certain neurotransmitter. So I think there's still a real stigma around any sort of, any sort of mental illness, if that's what you want to call it, or psychiatric disorder, and that people really, even a lot of individuals who are affected by these disorders, feel that they should be strong enough to take charge and just come out of this on their own, and they don't want to take medication. And I think it's really important for us to educate people that you would never say we're over-medicating diabetics or we're over-medicating hypertensive people, and I think that we have to be very careful with that in psychiatry. And and also we don't use antidepressants. I mean, the average professional in the field is going to be very careful. Not every patient that walks through my office door that is, you know, down or depressed, I'm going to, you know, put them right on a medicine. We're going to say, how impaired are they? Can they, you know, function in their life and do some therapy? And while they don't feel so great, well, maybe that's appropriate at that time in their life. They're going through something very difficult. Medication isn't the answer to everything, but it certainly is really helpful, and it saves lives because a lot of people, when they get severely depressed, will actually think about ending their lives at some point. So it's really important not to minimize the level of impairment that these people experience and why they need the medicines.
Great. Well, I'm glad you brought up suicidality, and I do want to talk about that. But first, I want to differentiate bipolar disorder from depression. Can you help us understand the differences?
Sure. Well, with depression, there's a couple of different levels of severity. And there's a condition called dysthymia, which is a very mild sort of form of depression, where people have this chronic, sort of sad, down, unmotivated, sort of just not enjoying life. It lasts for two years or longer to be diagnosed. And they're going about their business and doing what they need to do. Often they have milder symptoms of depression, so they're not having fun. They're not living life to their fullest. They're not achieving what they would normally achieve, or just, you know, having the joy that they could have. And then there's severe depression, or in levels in between too, where somebody really becomes disabled. Now, with bipolar disorder, it's a very, you know, severe condition. It can be extremely impairing, and actually in children and adolescents, there's a study done by Barbara Gella, who's a researcher in the field, and 50% of children who have depression early in life will actually convert to bipolar disorder by the time they're 20 years old. So it's really, they may have a predisposition to bipolar disorder, but they're presenting with depression first. So it's important to really watch these kids and look out for the symptoms of bipolar disorder. Even with adult onset bipolar disorder, your first episode or your first time of difficulty might be that you present with an episode of depression. And then later you could have an episode of mania. So mania is when you have the high ups, sort of out of character behavior. You can be high, silly, giddy, goofy, or have extreme irritability and rage, or be hypersexual, act out of character. You might have some grandiosity where you think you're better or more powerful or stronger or more successful than you actually are in reality. There can be some religiosity where people all of a sudden become very religious, and then they feel good when they're manic. So a lot of patients that have these highs don't want to be treated because they really feel good. But when they come down, they crash, really crash, and their depression is very severe. And with bipolar disorder, there's a much higher risk of suicidal thoughts and ideation, 29.2%, so almost a third of patients with bipolar disorder will actually attempt suicide, whereas with depression it's about 19%. And in other psychiatric disorders it's only 4.2%. So it speaks to the level of impairment and the suffering with depression and bipolar disorder. So people with bipolar disorder do experience periods of depression, but they also experience the highs. So they have sort of these cycles of the down, where they're really down and sad and unmotivated, to really high and on top of the world, and they can do anything.
Right. I want to just clarify a point about mania. I've heard people describe mania as feeling happy, and from what I understand, it's not happy at all. It's more agitated, like ants in your pants. Usually you could tell when somebody's in an agitated state by the way that you feel around them. Does that?
In children and adolescents, because of the developmental variable, you see a lot more chronic irritability and explosiveness. It's sort of one of the cardinal signs of bipolar disorder in children and adolescents. And some adults do have the rage and that irritability as well, primarily with their mania. But a lot of, and there's different levels of severity. So I do have adult patients who will say that they just feel great, and others who feel they're happy and they're having fun, but they know that they're doing things that are odd, or they're afraid of what they're going to do or say, or doing things out of character that can get them into trouble. Mm-hmm. Somebody who goes on a shopping spree and spends all this money and that they don't have. So often family members will encourage their loved one to seek treatment, because even though they seem to be having fun, they're doing a lot of damage mm-hmm. during that time. But there are some people that do just feel happy, but then they really crash mm-hmm. and suffer from that. So
okay.
it really varies in different individuals.
Okay.
Yeah.
There's something else I want to pick up. We talked about the fact that people who are experiencing mania don't tend to go get help because they feel so much better than when they felt depressed. And so commonly bipolar disorder is actually not diagnosed correctly. It's misdiagnosed.
Right.
They're diagnosed probably as having depression and not as having bipolar disorder, and you can really get into some trouble there too.
Well, especially with cyclothymia, which is a milder form of bipolar disorder. It's a little bit harder to differentiate, because when a person comes in for an evaluation, they may not report any of the symptoms or the periods of time when they were up and happy, or the things that were out of character for them, their behavior. And with cyclothymia, they have ups and they have downs, but it would almost be difficult for the average person to notice that they were really up. It would almost seem like, oh, they're just in a great mood, or they're mm-hmm. just so productive right now. And then you might not see them when they're feeling down or sad, because they may not be the person that can't get out of bed, but they're just not having fun, they're not happy, and they can get pretty depressed. The other thing is, with developmental variables, children and adolescents get misdiagnosed all the time. Mm-hmm. People for years would diagnose these kids with ADHD because of their hyperactive, endless energy, restlessness, the explosiveness and violence or agitation. They would write off as, conduct disorder or depression or oppositional defiant disorder. So they're becoming more aware that children and adolescents present differently than adults with bipolar disorder do. So part of what we're doing with our organization is trying to educate people so that more children and adolescents will get diagnosed earlier and avoid a lot of suffering that's unnecessary. Misdiagnosis is really a horrible thing, mm-hmm. because not only does misdiagnosis prevent the individual from getting treatment, but the medications used to treat something like ADHD or anxiety or depression will actually trigger a manic reaction mm-hmm. or a high level of agitation.
Wow. And I understand it takes about 8 to 10 years for somebody to get appropriately diagnosed with bipolar disorder.
In children and adolescents, from the onset of symptoms to the time they actually get an accurate diagnosis and treatment plan, it is an average mm-hmm. of 8 to 10 years. So you can imagine how much of their development has mm-hmm. been delayed, how they haven't acquired good social skills or learned as much as they could have. And a lot of them end up, into drugs. They self-medicate, and alcohol, and a lot of suffering, legal problems, because in 8 to 10 years you can do a lot of damage if mm-hmm. you're not feeling well.
Right. Well, speaking of damage, I think this is a good time to talk about suicide and suicidality. Can you talk about the incidence of suicidality and what you can do? There are lots of myths around suicidal people.
Right. I think that suicide is in the top 5 causes of death in the United States wow. today. So it's a very serious concern, and it is very high in the bipolar population. I think I mentioned about 1/3 of individuals with bipolar disorder will attempt suicide at one mm-hmm. time in their life. And of those individuals who do attempt suicide, 1 in 5 of the bipolar individuals will actually complete suicide, whereas in the general population, it's only about 1 in 10 or 20 that will complete suicide. So it speaks to the level of desperation that there have a much higher rate of completed suicide.
So when you say complete suicide, you mean they'll be successful. So 1 in 5 are successful.
Right.
With depression.
With
or with
bipolar disorder. Yes. And in depression as well, I think it's about 19% that actually attempt suicide as well.
Mm-hmm.
So you never want to underestimate how significant their depression and their impairment is, that they feel so hopeless and they really want to end their
Mm-hmm.
life. And I think, you know, one of the people don't want to talk about suicide, or even if they really love their family member or their friend, they often feel like maybe it's intrusive to ask them a question like that, or to bring that up. Would it give them the idea to do it, when in fact it should be talked about? And the only way to prevent a suicide and somebody that's desperate and can't really get the help themselves for whatever reason is to ask them, and to really approach them from an empathetic standpoint, not to judge them, not to try to solve their problems or give them answers, but to really listen to them and understand how they're feeling, and to inquire, you know, is there a level of danger there that you need to get them to the emergency room right away, or to give them the suicide hotline numbers that we posted a few minutes ago. There are the Good Samaritans, and there's other suicide hotlines that family members, friends, anybody can call and ask for advice. And the individual themselves can as well.
And those are all free services.
That's right. That's right. And it's really, people who are suicidal do give a lot of clues and warning signs. You may see them really start to, that they were so depressed and they start to be a little bit lifted because they've made a decision that they're going to end their life, and they feel some relief from that because they're suffering so much that they don't want to feel this way anymore. They may say goodbyes in sort of vague ways, or start giving things away, or getting their finances in order, or talking about their wills, or they may come right out and say, I'm going to end my life. I don't want to live like this anymore. I can't do this anymore. And I think that one of the myths is that, oh, if they're talking about it, they're just looking for attention. They're not going to really do it. And I think any talk of suicide always needs to be taken very seriously. And you need to find services. There's clinics in the area. There's hospitals, emergency rooms. Pretty much, but even if you just wanted to call one of the hotlines, they'll guide you as to where to get help in your area and how to approach that situation.
Yeah, another point that I wanted to bring up that you reminded me about was the fact that when a depressed person feels more energetic, sometimes that's the time when they will actually have the energy to try and commit suicide.
That's right.
Not when they're sleeping all the time and and can't move. It's when they start to get a little bit more energy that actually can be a lot more dangerous.
That's true.
I want to emphasize again what it is that you can do for someone that's suicidal. So ask them directly, are you feeling suicidal? Do you have a plan?
Right.
How would you kill yourself if you really felt like you wanted to? If they talk about a plan that they'll take pills or they'll shoot themselves, ask them, do you have pills? Where are they? Do you have a gun? Where is it? Is it loaded? I mean, really get into detail so you can determine how serious it is, and then determine what your next step should be.
Right.
But again, I like that you definitely underlined how important it is to take them very, very seriously.
Right. And even if you don't feel they have the means to, if they say, I would kill myself with a gun, but they don't have one, the fact that if you're not really a professional, and the fact that they're expressing that to you is really, they're really reaching out for help, and it's really important that you get some sort of professional advice on how to help them or get them to a place where they can get help.
Right. Well, speaking of advice and help, this all sounds very challenging and very difficult for the person who's going through this, but I can imagine that for their loved ones, spouses, friends, colleagues, family members, it's really, really difficult as well. Can you talk about some support that might be available to them?
Sure. Depression and bipolar disorder, or the milder versions of either, are very impairing for the family as well. You can imagine a parent with a child that's agitated and out of control and becoming violent, or creating scenes everywhere they go, that It can cause a lot of marital discord. Parents blame each other. They disagree on disciplinary efforts. Brothers and sisters are very resentful of their sibling who ruins their family outings, or they can't go to restaurants or just certain places because the child's going to really act up. And depression, sometimes, you know, the child will withdraw from a football team or soccer, something that they loved and their parents really loved to see them doing, and the parents are pressuring them to go, and they're disappointed, and the child doesn't care anymore. And parents are usually at a loss. They don't know what to do, and the average parent doesn't know, isn't able to define, oh, my child's depressed. They'll often think, oh, they're an adolescent, or it's the terrible twos, or they're just having a difficult time. And I think the most important thing that I would say to families is to get some education, to understand the disorder, whether you have a child or adolescent, or if it's a friend, or it's an adult, it's your parent, your loved one. It's going to be impairing to the whole family, even to friends, because if you love this person, you suffer watching them suffer. If it's somebody you're married to and they don't want to go out anymore and they don't have any interest in doing fun things or talking to you, and it's very difficult. There are a lot of different groups out there, and if you do searches on online or go to a library, they can help you to find organizations in your area. Our organization, Step Up for Kids, runs parent support groups for parents of children and adolescents with bipolar disorder or other emotional and behavior disorders. Everyone's welcome. We also do educational events, and anyone that needs an educational event, we're happy to come out and put that on for them. And we have a great networking event coming up on November 11th where families who want more information about these disorders could come and meet some of the experts. It's a charity dinner and a blues festival, and the James Montgomery Band is playing, and Monster Mike Welsh, and there'll be an
local
auction.
legends.
Yes.
Yep.
So it should be a really fun night, and also Dimitri Popoulos, the author of The Bipolar Child, and Janet Wozniak, who's a Harvard researcher and the co-author of the book that we're writing together, Walking on Eggshells, which is about children with bipolar disorder, will be available to answer questions, and we'll have an education table. So it'll be a good opportunity for people to come out and meet some of the experts, meet other families, talk to people, get some educational information, and it should be a really fun night.
Great.
If people are interested in that, they can go to our website, which is www.stepup4kids.com.
Great. So that's in a couple weeks on Saturday, November 11th. So
from
we'll
8
be
to
sure to check
12.
that out.
It's 8 to 12, and it's at the Freeport Hall in Dorchester.
Okay, great.
And they also can just go to our website for more educational information, and we write newsletters. They can email me. My contact information is on there, and we'll put them on our email list and send them newsletters with updates of information.
Great. You know, we talked a lot about, you know, the different levels of disorders, depression, bipolar disorder. You know, it seems that there are a lot of successful, very creative, very functional people who have either bipolar disorder or depression. I know from doing my own research, you know, Jane Pauley, Edgar Allan Poe, Vincent van Gogh, Patty Duke, really just spanning across politics and arts and entertainment and so on. So having these disorders, suffering from depression or bipolar disorder really is not a death sentence at all.
Absolutely not. I met with a man today who is extremely successful, who really wants to help with our foundation, who has bipolar disorder, and he said that it was a gift because it has given him this creativity and this energy and the ability to really do things in life that many other people don't have. There are a lot of very creative people. A lot of the patients I treat are musicians, they're artists, they write unbelievably, even some of the kids. So there are a lot of gifts with this disorder, and if it's treated properly, you really can avoid a lot of the suffering. And not every client that you see or help is going to become completely stabilize the day that you see them. Sometimes it takes time, sometimes it's tricky, using different medications or therapy, or there's different therapeutic approaches out there, like Ross Greene's method. He wrote The Explosive Child, which is collaborative problem solving with a child that has bipolar disorder. There's a book out by Kay Redfield Jameson, who's a psychiatrist, about bipolar disorder. There's a lot of different resources out there, but it really speaks to treatment of any early intervention and effective treatment of any disorder. You can have a really great life, but it's important to seek help, and not to, any disorder that you leave untreated is going to get worse, and there's going to be more complications, and the same is true of these psychiatric disorders.
Right. Okay. Well, now's a good point to transition over to mood disorders. Talk a little bit about, to anxiety disorders. Talk a little bit about anxiety disorders, please.
Okay. There's quite an overlap between mood disorders and anxiety disorders. In fact, most people who have bipolar disorder also have anxiety disorders. A lot of people with depression have anxiety. Sometimes when there's a stressful life event, when you think about something like post-traumatic stress disorder, which is an anxiety disorder, someone has been exposed to a trauma, something that's really triggered a tremendous amount of anxiety in them, and also they suffer from depression from having suffered from this trauma and the demoralization from that. So, and people also just have like general anxiety disorder, where they are sort of anxious and fearful in general about almost anything. You have individuals with social phobia who are actually anxious in social situations, so they may be fine at home or in work or other places, but when they get out into the social environment, they may avoid or not go to a party or not go to an event, or sort of freeze up in an event where they feel, they feel this anxiety. So there may be some avoidance of situations, of fearfulness that they're going to experience that, or panic attacks, which are very significant and really need to be treated, because panic attacks are actually, there's a physiological response. When a person that has panic disorder thinks about something that creates some anxiety for them, they actually have a physiological response where their heart will be pounding, they may feel nauseous or have GI distress, they may feel dizzy, short of breath. Some people will describe they have like pressure in their chest, that they feel like they're having a heart attack, or they almost feel like they're going to die. It's so bad. And then they will fear that they're going to have one of these attacks again. These attacks are so horrible that it's almost like a snowball effect. So it's really important to get treatment for any of these disorders so that it doesn't snowball out of control. There's also specific phobias. Maybe someone functions very well and they're not anxious in their general life, but they're afraid of flying, or they're afraid of, a certain bees or elevators. And a lot of these things can be treated with therapy, exposure therapy, but sometimes, in many cases, they'll need some medication too.
Okay. I wanted to just ask briefly, most of us, again, feel anxious every now and again, and how do we know what a panic attack is? How long does it last, versus I'm anxious about this test I have to take, or I have to break up with my boyfriend, it's making me really nervous.
Right. Well, the average person will have anxious moments. Everyone has anxious moments, before you take a test, like you mentioned, or a lot of people will, with public speaking, if they're going to be interviewed or they're going to do a presentation at work or at a conference, will have extreme anxiety, and they may even have to take something prior to their talk. Other people really will work through that with therapy. But those are situational anxieties that would cause the average person some distress, some nervousness, some worry. But with anxiety disorders, such as a panic disorder, you would never not know that you were having a panic disorder. It's so severe and so impairing. And it's like a complete loss of control of of this intense fear and panic.
How long does it last?
It can last usually minutes, and usually people will come out of it, but it's so intense that, and some people actually end up going to the emergency room thinking they're having heart attacks. It can last for, for a significant amount of time. But even if it only lasted 2 minutes, it's 2 long minutes. It's very severe.
What can you do for it?
Well, there are medications to treat panic disorder, and also therapy is helpful. Usually someone with a severe panic disorder would need some medication to intervene and while they're working through therapy, because it's an awful thing to experience, and they're so worried that it's going to happen again that they will start to avoid situations. And so I think the average person who has anxiety, they may lose a little bit of sleep the night before some big event, and they're worrying, or they're thinking a little bit too much about it. But with an anxiety disorder, it actually keeps them from doing things. They can't pay attention because they're so worried, so they can't focus. They will avoid situations or places that make them anxious. Somebody with obsessive compulsive disorder, which is an anxiety disorder, they have obsessional thoughts that they can't get out of their head, and it's anxiety driven. So then they have these rituals that they need to perform. And if they can't perform, if somebody was to try to prevent them from performing those rituals, they would become really distressed because they fear something really horrible is going to happen if they can't do these rituals. It could be anything from tapping or counting or repeating a certain behavior. Some people will, one patient of mine, it would have his father drive in and out of the garage a certain amount of times before he could actually put the car in the garage. And if the father wouldn't do that, he would really panic and scream and yell and carry on forever. So sometimes families don't know what to do, and they'll engage in the rituals that sometimes a child will actually have their family engaged in the rituals.
Is that the best thing to do?
Well, you really need to, it isn't the best thing to do. I think whenever any sort of anxiety is impairing for the family or the person in any level or any area of their life, they should seek help from a professional. And cases are individualized, and the therapist or physician or nurse practitioner will work with the individual case and come up with a strategy and teach parents or loved ones how to deal with those situations, and if they need medication as well. So the bottom line, to answer your question, is normal anxiety does not impair you from going through your functions in life. It does not keep you from achieving. It doesn't force you to avoid situations or places or things. You can walk through it and if you feel uncomfortable, but it doesn't stop you in your tracks. And severe anxiety does stop people in their tracks.
Okay. That reminds me of a movie with Jack Nicholson, I think it was called As Good as It Gets, where he has to turn the lock a certain amount of time and walk a certain amount of steps.
That's right. That was a great movie, and it was really powerful in showing how impairing a severe case of obsessive compulsive disorder can be in relationships and every area of their life, and the time that it takes up and the energy it takes up in their average day, that when they should be thinking about other things or enjoying their time or life, that they're just worrying and obsessing. It's really a sad disorder to have for these people.
It reminds me also of stories that David Sedaris wrote about his childhood. I don't know if you've read that, but he writes about having obsessive compulsive disorder and having to do certain things and being very ritualized. And of course, especially locally, if we know about David Sedaris, some of his family members are here in town and are very successful, and he's very successful. So again, it goes back to the same point of folks with depression, bipolar disorder. It's not a death sentence. It's you can be creative and successful and functional, assuming that you have the right treatments.
Absolutely. And I think that's really an important point. So many families, children, adults, whatever age you are, when you get this kind of diagnosis, some people feel like they're a failure or that that's it for them. They're not going to be able to live a normal life, and it's just not true. with proper treatment, they can live perfectly normal lives. And if they seek help, and there are so many very successful people that perform on stage. There are celebrities who will say they're so anxious before they go out there, and you would never know that or see that. You don't know what's going on with people. And I think that a lot of individuals with these kind of disorders feel very alone, or think they're the only ones that have that, and that they look around and no one else has this. Look, they can do this or that. And you don't know who's taking medications and who has been in a lot of therapy, and that's why they can be the way they are. And you'd be very surprised at the professionals, lawyers, doctors, people in the media, celebrities, golf pros. They're all walks of life. This is, these illnesses affect people from everywhere, all ethnic backgrounds, ages, and they can be extremely successful.
Yep, great. Let's talk a little bit about statistics. I know that we mentioned 1 in 10 are probably suffering from some kind of mood disorder. What do we see in kids, for example?
Children and adolescents with bipolar disorder, they're saying, the research recently has shown that up to 6% of children are affected with a certain type of bipolar disorder. So there are different levels of severity, bipolar 1 being the more severe, bipolar 2, which they don't have the severe manic episodes. They might have a little hypomania, but they haven't had the real mania, the real significant mania, or cyclothymia, or we have this category called bipolar spectrum disorders, meaning that the child or adolescent may be very impaired, but they don't quite meet the diagnostic criteria as defined in the DSM-4, which is our diagnostic manual for people in psychiatry, that we use a criteria to define a disorder. So they still need treatment, and they're very impaired. And when you add the numbers in of those with bipolar spectrum disorder, it's up to 6% now. Wow. In adults, the last statistic that I saw in the National Institute for Mental Health was 2.7% of adults that have bipolar disorder, and that I would bet that is bipolar 1 and bipolar 2.
And I wonder if that's a really low number, too, given the fact that lots of folks don't actually go to their physician's offices when they're in the manic state, but in the depressive state. So they might be misdiagnosed as being depressed.
Right.
Or
they may not seek treatment at all.
Or they
That's
might not.
true, especially in certain age groups. There are different opinions about psychiatry. I think in our parents and their parents, those generations are much less open to any kind of psychiatric intervention. And a lot of the families that I see, I'll ask, do you have a history of depression or bipolar or anxiety? No, but I had a crazy aunt. Or, my grandfather was out of his mind and he went into some sort of hospital. So, but they've never labeled, they've never been diagnosed. They just know, we have these relatives who, they're crazy, or they're, completely out of their minds. They say things like that. And so nobody's ever really recognized that they have a disorder that could be treated, and that they're not crazy. They're not out of their minds. They just have an illness that needs some treatment.
Are these disorders hereditary?
Oh, yes, they are. They're very hereditary.
Yeah. Or is one more hereditary than the other? Or?
Well, they're doing a lot of genetic research in bipolar disorder currently to really, they're trying to look at different subtypes that might be hereditary. They know that bipolar disorder is hereditary. They haven't identified the exact gene, but they're doing a lot of the PET scans and looking at the brain and the different regions of the brain and how it's involved. And a lot of the studies have shown, that if you have a history of bipolar disorder, you're a much higher risk of developing bipolar disorder. Same with depression and anxiety disorders. And there's a doctor at Mass General, Dina Hirschfeld, who's actually looking at research in children for inhibition versus disinhibition. So she's looking at children who are inhibited from the time they're really young, that they're shy.
What do you mean?
They're very shy and withdrawn, and they're not as apt to engage, and that those children often grow up to have anxiety disorders. And that the children who are very disinhibited, which means they sort of are a little over the top more than the average child, that they will reach out to strangers and run around and have fun even if they don't know anyone, and which seems to be a great thing, but that the more disinhibited they are, the higher risk they are for developing one of these mood disorders or behavioral disorders. So, and they are studying, looking at parents and children and the family history, so there are definitely hereditary disorders, and there are probably a lot of environmental factors too, aside from if you're a child and your mother is afraid of elevators and you grow up knowing you can't go in those elevators, or you can't go on a plane, and your mother or father is hyperventilating because they're having a panic attack, it's going to scare you.
Right.
So there are environmental causes as well, and the same with depression. If you're around a mother who's always sad and down and she doesn't want to go places, or a father or anyone, you think about when you're out with your friends, if you're with a very depressed friend and they're crying and really sad, it brings you down.
Right.
So if you live with somebody like that, certainly you're affected. Your moods are going to be affected by somebody that's very angry, agitated, explosive, or just really sad, and it's somebody that you love. So it does affect people.
Right.
Yeah.
I want to get back to something that we touched on earlier, which were treatments. We mentioned that medications are really important to take. Coupling that with therapy is really important. Let's talk specifically about some treatments. There are some medications that everyone can name. Prozac, for example, Xanax. Can you help sort of demystify what these medications are?
Sure.
What they're used for?
The medications that are most commonly used to treat depression are the serotonin reuptake inhibitors, and those are the things that we know commonly as Prozac, Zoloft, Paxil, Celexa, Lexapro, or Effexor, which is has a norepinephrine and serotonin reuptake inhibitor. So it's a little bit different, where it hits some other neurotransmitters. There are also the tricyclic antidepressants. So they're just different.
Those are the older medications,
They're older
right?
ones, yeah. The majority of people first line are using the SSRIs or Effexor type medications, like, the Zolofts and all of the things that I've mentioned. They're very effective, and with any medication there can be side effects. They're usually well tolerated in people. One of the things that you have to be really careful of is when you're differentiating between depression or dysthymia versus bipolar or cyclothymia, you want to make sure that you have the right diagnosis, because if you give a person with bipolar disorder an antidepressant, they'll become very manic in a lot of cases.
And that would be very bad.
Right. Yeah. But if you're treating somebody for bipolar disorder and they're on a mood stabilizer or a medication that really works for them, and they have some residual depression or some anxiety, you can then add very carefully an antidepressant or anti-anxiety agent and just monitor them very closely, and you warn them that there could be a risk of some activation or mania. But many people, when they're on a mood stabilizer, will need an additional anti-anxiety or antidepressant medication, and they can tolerate that. Now, the treatments for bipolar disorder are the mood stabilizers, anticonvulsants are used. Even though they're approved for seizure disorders, they have mood stabilizing properties, some of them. The atypical antipsychotic agents, which are Risperdal, Seroquel, Zyprexa, Abilify, Geodone, those medications are used very commonly, or lithium or Depakote.
They're used commonly for which?
For bipolar disorder. So the first line with a mood disorder is to stabilize the mood.
So you called those antipsychotics.
Antipsychotics, yeah, it has a very negative connotation, and people worry when you say that. You're putting me on a psychotic medication. I'm not psychotic. But in fact, we use seizure medications to treat mood too. Those medications have been marketed and studied in a population for seizures or for psychosis. However, through those studies, they've come to know that they also really work for mood. So they're used, and many of them have been studied in mood, and some of them have FDA approval for mood indications. So, and as far as the anxiety goes, you also will use some of the serotonin reuptake inhibitors, the Prozac, Zoloft, Paxil, that Lexapro, Celexa group, do work for anxiety. There are also benzodiazepines, which are your Xanax, Klonopin, Ativan, Valium-type medications, which with panic disorder, sometimes you'll use them temporarily until you can get a person on an SSRI, because it takes about 4 to 6 weeks for an SSRI to be effective.
That's the treatment for depression. It takes about 4 to 6 weeks.
That's right.
But it can take less?
Some people will start to feel better in a shorter period of time, you know, within a few days or weeks, but others it takes a while, you know, 4 to 6 weeks. So you don't want somebody to be suffering from panic attacks for 4 to 6 weeks if they're one of those people that it really does take that long for. So you sometimes will use a benzodiazepine short term until the SSRI kicks in, and you just have to be careful with abuse potential, because it is a drug that people can abuse. So if somebody has a history of being addicted to drugs, that you probably would be very cautious about using a medication like that in that population.
Can you give us some examples of medications like that we should be cautious of?
Well, the benzodiazepines, absolutely.
For example?
The Ativan, Xanax, Klonopin, Valium type can be drugs of abuse.
Right, okay.
And people can become very addicted to those drugs, just as they would to any of the narcotics and even the treatments for ADHD, like the stimulants, people can abuse. If taken properly, they're effective, good medications, but they have street value because they can potentially abuse them and get high from them. So you have to be very careful about who you use them with, how you prescribe them, and monitoring them. But they are effective.
Now, I've heard OxyContin and Valium, I've heard those talked about sort of, you know, in the general public as being drugs that have been abused. Are those all used also for anxiety typically?
OxyContin is really only used for severe pain, such as in cancer patients. We don't use that in psychiatry at all. It is a medication that's received a lot of press because it's so highly abused, and it has such a high street value, and a lot of people become addicted to that. They buy it on the street, and then they'll end up switching over to heroin because the OxyContin's too expensive, or they can't get it, and the heroin's cheaper. So you really need to be careful with those kind of medicines, and there's a lot more scrutiny around prescribing them, but we don't use that in psychiatry. The Valium is a benzodiazepine, and we would use that, like I mentioned, but carefully.
Right.
But you're always careful. There are medications that we use in psychiatry that can be abused, and so you want to really have an understanding, have a good rapport with your patient. Also, you know, if it's a child, then the parents can lock it up and really monitor it and give it to the child. If it's an adult, if there's somebody in the house that's a drug addict, you want to be careful about that. You really have to know your patients and know, you know, if they do have a history of addiction, you want to be careful. But they can be very useful drugs for the right person.
You talked about kids. Would you prescribe these agents, these medications for children?
Absolutely. One of the real disadvantages of treating children and adolescents is that there's very few drugs approved for that age group. So we're prescribing most medications off-label, is what we call it, because they've been studied in adults. And there are research studies out there from different researchers in different academic settings who have done great research studies, but they're smaller populations, or the drugs just aren't FDA approved. It doesn't mean that we don't know anything about them. It just means that there hasn't been extensive years of research that you'd need to get FDA approval. So a lot of the medications that we do use, some have been studied in children and adolescents in smaller studies, but a lot of them are not FDA approved. So that is something that you know, a lot of people are working on, and pharmaceutical companies are starting to do more research in children and adolescents. So we're hoping that in the future we'll have a lot more information.
Right. So there are a lot of kids that we hear about that are medicated, you know, Ritalin and, you know, other agents, other drugs for ADHD, and you talked about bipolar disorder in children. How does a parent sort out what's okay to take, what he or she should do? It seems like it could be very confusing.
It is very confusing. And I think that, you know, coming to organizations like ours, where you have professionals who are doing educational programs, that's a way to get education. The National Institute of Mental Health has a website with a lot of information. Some of the drug companies on their website actually have published research studies that you can actually go on and read. You really want to educate yourself about all the risks and the benefits of the medication. If your child's very sick, or your husband or wife is very sick, not treating them is not really an option, because they're going to suffer. So then you have to consider, what are the risks of the medication, but what are the risks of not treating, and then what are the benefits, and do the benefits outweigh the risks of medication treatment? And you just need to really get the education and to find a professional or a clinician that you really trust, and work with them to help you make that decision. You know, I will always work with families, and I'll give them the information. This is what could happen. Some people do have side effects and negative outcomes. Others improve dramatically. What are we looking at here? You know, if the person's suffering, we've tried other things, and this is a good option, but they may have some weight gain, or they may become activated or drowsy or sedated. You have to really always weigh the risks and benefits, and make an educated decision from there.
Right. Good. Well, we're almost out of time. I wanted to thank you so much, Marianne, for joining us. Also wanted to remind everyone that there is a benefit happening in a few weeks. That would be a great resource for local folks, parents, and other folks who might be interested in coming to learn a little bit about the support that's available out there. They could talk to you. They could reach you by this website.
Right.
There's lots of things going on. Any other last words?
No, thank you for having me. It was really great to be here.
Wonderful. Well, thank you very much. We look forward to seeing you next time. Thanks for joining us at Dead Air Live.